The inferior alveolar and lingual nerve blocks are indicated for pain management of one quadrant of the mandibular arch, including the floor of the mouth and the anterior two-thirds of the tongue. Internal landmarks include the pterygomandibular raphe, the internal oblique ridge, and the coronoid notch. The clinician is pointing out the pterygomandibular raphe in the video. The thumb is placed on the greatest concavity of the coronoid notch, pulling the tissue tightly. A Q-tip can be utilized to identify the penetration location. Note in the video, the clinician is identifying the deepest portion, rocking the Q-tip over the contralateral premolars to view both the angulation and penetration. The Q-tip and the thumb are lined up so the middle of the thumbnail is even with the Q-tip. This assists the clinician during penetration to re-identify the insertion location. The anatomy of a patient's ramus can vary widely, including the flare and the position of the lingula. Once the clinician has determined the appropriate retraction and identifies bevel and window placement as well as stability of the syringe, the penetration angle will be over the contralateral premolars at the commissure, at 2 to 3 millimeters above the greatest concavity of the coronoid notch. If premature contact occurs, the clinician can withdraw the needle slightly and reinsert. The position for the lingual nerve block will be the same as the IA, with a difference in depth and dose. Extended verbals for the inferior, alveolar, and lingual nerve blocks. The medical history has been reviewed, there are no changes, and the vital signs are within normal limits. There are no contraindications for local anesthesia. I will be using 20% benzocaine topical for 1 to 2 minutes, 2% lidocaine with a 1 to 100,000 epinephrine, and an expiration date of January 2018. I will be using a 25 gauge long needle. The injection is the inferior alveolar and lingual nerve blocks. The IA anesthetizes the mandibular teeth in one quadrant and the buccal soft tissue from centrals to premolars. The lingual anesthetizes the lingual soft tissue in the quadrant, the floor of the mouth, and the anterior two-thirds of the tongue. The insertion site is slightly superior to the greatest concavity of the coronoid notch, lateral to the pterygomandibular raphe, and medial to the internal oblique ridge. The depth of penetration is 20 to 25 millimeters for the IA and 10 to 12 millimeters for the lingual. The deposit site for the IA will be slightly above the mandibular foramen, and for the lingual, approximately halfway between the penetration and deposit site for the IA near the lingual nerve. The landmarks for both are the pterygomandibular raphe, the coronoid notch and border of the ramus, and the internal oblique ridge. The pathway is at the commissure over the premolars on the contralateral side. The dose range for the IA is 1.2 to 1.3 milliliters, and for the lingual will be 0.1 to 0.2 milliliters. Complications include edema, pain at the site, and hematoma. Communication during the injection is important to both patient and faculty. Encourage the patient with positive feedback. Note, for the lingual, there may be a shock-like sensation. This is normal. Reaffirm with the patient that that is fine. For the faculty, let them know when you have reached your landmark. Also, verbalize when you are aspirating and the results of the aspiration twice. Also, let them know when you are prepared to deposit solution. Keep in mind that the aspirations will occur for both the IA and the lingual. Additional complications to consider may be post-injection muscle soreness, possible trismus, or paresthesia, which is typically transient. Another common complication is a 10 to 15% positive aspiration rate.